Okay. So today we'll be discussing about hypertension. So hypertension is a very common disease. It is very prevalent all over the world. And so to make the diagnosis of hypertension, first of all, you have to measure the blood pressure. And if the blood pressure is above a specific threshold, above which there is increased risk for cardiovascular disease, then we consider it the hypertension. Various societies have given the various types of definition, but we'll stick to some definition given by the American Heart Association and JNC. So considering the epidemiology, so it is a leading cause of death globally. According to a study, Framingham Heart Study, with the increase in the age, there will be the increase in the prevalence of the hypertension, even if you are normotensive till the age of 55. For example, if you see the people of 55 years old who is a normotensive, and if you follow that patient to the age of 80 years, or then 90% chances of that person being hypertension is present there. Similarly, in a study done in Nepal, the prevalence of hypertension was found to be 33.8%. In the people living in the South Asia, they have a unique kind of the cardiovascular risk profile, like high risk of diabetes, higher percentage of the body fat, and the low LDL concentration compared to the other ethnic groups. So these differences in the risk factor also increase the chances of hypertension in this South Asian population. Considering pathogenesis, in more than 95% of the cases, there won't be any underlying causes. You won't be able to find the causes of the hypertension. So we call those 95% of the patients who don't have any underlying cause the essential hypertension. So the for the controlling of the blood pressure, there are various factors which include renal dysfunction can cause hypertension. Similarly, peripheral resistance, basal tone, and the endothelial dysfunction also has an important role in maintaining the blood pressure. And if any dysregulation is present in this system, there can be the increase in the blood pressure, which we call hypertension. Similarly, the autonomic tone of the body has also contribution in maintaining the blood pressure. Similarly, insulin resistance and the other neurohormonal factors like renin-angiotensin system, as well as corticosteroids, they have an important role in maintaining the blood pressure. So another risk factor is the age. Age is a very strong risk factor. So most of the people develop hypertension with the increase in the age. And there are other environmental factors which can be modified, like high salt intake. If we can cut off the salt intake, there we can decrease the chances of developing hypertension. Similarly, heavy consumption of alcohol, obesity, and the lack of exercise are also the factors which are responsible for hypertension. And the other factors which cannot be modified, like impaired intrauterine growth and the low birth weight, these are also the risk factors for the development of the hypertension. So you need to consider all these risk factors while seeing a patient in the OPD. You have to evaluate, we have to ask history about these things, and you should ask patient to modify their lifestyle so that they can live a healthy life. So in about 5% of the cases, hypertension is secondary to the specific causes. As I mentioned, in 95% of the cases, you won't be able to find any kind of the causes or any disease that is causing hypertension. But in 5% of the cases, you can identify some diseases which are responsible for the hypertension. That group of the people who have hypertension, we call them patients with secondary hypertension. So we'll now talking about the natural history of hypertension. So when a person develops a hypertension, in the initial stage, they will be in the asymptomatic stage. And if we don't treat them in the asymptomatic state or in the stage 1, stage 2 hypertension, then they will start to develop the organ damage. So we have to, the main goal of seeing patients in the OPD is to identify these patients before they develop organ damage. So we should screen for that. And if the patient has already developed asymptomatic organ damage, then if hypertension is not treated, then they will develop the other like features like left ventricular hypertrophy, retinal changes, similarly the renal impairment due to the hypertensive nephrosclerosis, and the other peripheral organ damage can occur. And if we don't intervene in this stage, then patient can have these symptoms of the organ damage. And if you even don't treat at this stage, there will be the failure of the various organs, like the patient will present with heart failure, as well as the cerebral vascular disease like stroke, as well as peripheral vascular disease like peripheral arterial disease, or as well as coronary artery disease, and the renal failure. And in the last, it can cause the death of the patient. So you need to understand the natural history of the disease so that you can counsel the patient and treat them accordingly. So now classifying the hypertension. Classification is basically based on the whether it is primary, that is essential, or it is secondary. So this primary hypertension is the hypertension in which you cannot find any causes. So in 95% of the cases, it is familial. So, and the elevated blood pressure can result from the complex interaction between the various genetic factors as well as environmental factors, like I told you, like obesity, salt intake, as well as the alcohol consumption. All those things can cause the essential hypertension. So basically the onset is between the age of 25 to 50 years, but they can present later or even in the earlier age group. However, if people present in the earlier age group or in the late, in the very elderly age, then you have to screen for the other secondary causes also. So there are various endogenous and the environmental determinants which are thought to be responsible for increase in blood pressure in this category of the patients. And basically, it's due to overactivation of the sympathetic nervous system, as well as the activation of the renin-angiotensin system. And similarly, there is blunting of some physiological responses, and due to some renal development issues can also cause essential hypertension. Although the cause is not identifiable in this 95% of the patients with hypertension or in the essential hypertension, there are some exacerbating factors, or there are some risk factors which can be mitigated for the proper management of the hypertension. Some of those factors include obesity, presence of a sleep apnea, as well as this high amount of salt intake, alcohol use, cigarette smoking, as well as use of the over-the-counter NSAIDs and any other types of the sympathomimetic drugs, as well as the low intake of the potassium. These are the factors which can be responsible for the increase in the blood pressure. So you have to ask the things and examine the patient properly to elicit the signs due to these risk factors. So secondary risk, next is the secondary hypertension. In the second classification is secondary hypertension, and this hypertension, as I have mentioned, is mostly due to the other secondary diseases or specific causes. So we should always try to differentiate whether it is primary or essential hypertension or the secondary hypertension. As you can see in this picture, if you see these conditions in a patient with new elevated blood pressure, like presence of the drug resistance, hypertension, abrupt onset of hypertension in the onset in the very young age, and the presence of the target organ damage at the time of presentation, as well as presence of the diastolic hypertension in the older adults, and the presence of the other dyselectrolipemia like hyperkalemia or hyperkalemia, then you should suspect the presence of the secondary causes of the hypertension. And this special group of the patients with these features or who meet this criteria should be screened for the secondary hypertension, and they should undergo the extensive investigation to find out the cause. Because in the secondary hypertension, if you can identify the cause and treat the cause, then the patient can revert into the normal tension. So it is very important to identify the secondary hypertension in relevant cases. There are various causes of the secondary hypertension. Mainly, it is divided into the various categories, and the various systemic diseases like renal diseases, including the renal cyst, polycystic kidney disease, as well as tumors, obstructive neuropathy, and other renal vascular disease, any adrenal diseases, as well as the coarctation of aorta, obstructive sleep apnea, as well as other miscellaneous endocrine diseases like hyperthyroidism, and the use of the over-the-counter medications. Like in our OPDs, we can see the various patients who are taking decongestants and the steroids from the medical shop, and they present to our OPD with the increase in the blood pressure. So in that cases, we can ask patient to stop those drugs, and we can counsel them about the use of those medication can lead to hypertension. So we have to very carefully look at the history of the patient and their lifestyle to identify the causes of hypertension. Right? So there are some rare second causes of the secondary hypertension, which include some Mendelian forms of hypertension. You don't need to know this in detail, but you should know the name of some syndromes like Liddle syndrome, as well as some 17 alpha hydroxylase deficiency. These are the some forms of the diseases which can cause hypertension. So we don't screen for we don't screen every patient for these conditions, but if there are some other features suggestive of these diseases, then we have to screen these conditions too. So talking about definition, there are various definitions given by the various institutions all around the world, but for the exam purpose, you should at least know this JNC 7 classification, and recently there is also JNC 8, and you should also know this ACC AHA, American College of Cardiology, American Heart Association 2007 classification. So basically, you can follow any definition, but one important thing is the cutoff value. In most of the definition, this systolic blood pressure of more than 140 is considered to be the threshold for starting the treatment. So you should know that. So any patient who presents with the blood pressure of more than 140/90, then you should consider treating them depending upon the cause. So according to the JNC, hypertension can be divided into stage 1 and stage 2. Similarly, again, according to AHA also, you can classify into stage 1 and stage 2. So you should know these definitions. So there are two terms which you need to know while treating a patient or while seeing a patient with hypertension in the OPD. So one is white coat hypertension and the masked hypertension. White coat hypertension is a condition in which a patient will have the increase in the blood pressure when you measure the blood pressure in the hospital or any healthcare worker. If they measure the blood pressure will be on the higher side or it will be high. But if the same patient is measuring blood pressure at home by some ambulator, some devices in the home, then blood pressure will be normal. That means only the blood pressure will be increased in case of the healthcare setup or when it is examined by the healthcare worker. That is known as white coat hypertension. Similarly, there is one type of the hypertension where blood pressure will be normal when measured by the healthcare workers in the hospital setup or in the clinic setup, but it will be increased when they measure at home. That is known as masked hypertension. So we need to know about this condition, because if we miss these two categories of the patient with the white coat hypertension and the masked hypertension, these patients may go unnoticed and they may develop the target organ damage because of our improper diagnosis. So we need to consider these two facts while diagnosing the patients of having hypertension. So blood pressure measurement. So you all need to know how to measure the blood pressure. And there are various approaches to measure the blood pressure. However, you can use either conventional office BP monitoring using the sphygmomanometer or the mercury manometer. Similarly, there can be automated devices can be used in the office to measure the blood pressure. Similarly, patient can measure measure blood pressure in their home using any kind of a validated BP monitors, or patient can be monitored for, or the BP can be measured using any kind of the ambulatory BP monitoring system. So for the diagnosis, it is very important to measure the BP accurately to make the accurate diagnosis, because once you start patient on the treatment for the hypertension, they should usually take the medicine for the lifelong. So when most of the patients are reluctant to start the medicines, so you need to make sure that the diagnosis is right, and you have to counsel the patient to start the treatment. So it is always important to measure the blood pressure accurately before starting the treatment. So what do you need to know before taking the blood pressures? So it is taking blood pressure is like multitasking. You have to listen the sound, as well as you have to feel the pulse. At the same time, you have to remember the reading. So you should be very attentive, and you should master the skill. So you should keep practicing doing this, because once you come in exam hall, you will forget how to take BP. So I hope you will try to take the BP properly. So this is how you should take the BP. The patient should be seated properly with the back supported, and the patient should not talk during or between the measurements. The cuff should fit the arm side. Actually, the cuff should be at least 75%. Bladder of the cuff should be at least 75% of the arm circumference, and the arm should be resting, and it should be at the level of the heart. And the room should be quiet, patient and at the comfortable temperature. Patients should not have smoked or taken coffee or tea or exercise for the last 30 minutes. The patient should have empty bladder. Patient should be relaxed for 3 to 5 minutes. And you should take at least 3 measurements or at least minimum 2 measurements at 1 minute of interval. And you should take the average of these 2 measurements. And while using the cuff, you should use the standard size cuff according to the size of the patient. And you should, if you are using any electronic devices, you should use the validated type of the or the recognized type of the instrument to measure the BP. So on initial evaluation, if you should measure the blood pressure in the both arms, and if there is a discrepancy between the blood pressure in the both arms, then those blood pressure with the arm with the higher BP should be taken as the value. And if the difference between two arms is less than 10, you don't need to worry. If it is more than 20, then you should consider further investigation. You have to rule out other secondary causes like coagulation, as well as various kind of the cervical rib, or you should rule out the other causes of the elevated hypertension, elevated blood pressure. So and in some patients, some patients, you have to also take the standing blood pressure. Like any patients who have diabetes, they usually have the autonomic failure. So in those patients, you have to ask patient to stand up and take the blood pressure in the sitting as well as in the standing position to see the difference. As well as in any patients in whom you have recently started on the BP medications, they should also be tested in the standing position also to see for the postural hypertension. This postural hypertension means decrease in the systolic BP more than 20 and diastolic BP more than 10 in the standing position in comparison to the sitting position while taken within the 3 minutes of standing. You need to know this thing. So this should be basically done in the patients with autonomic failure, for example, in the diabetic patients or any patients who presents with dizziness or in the state of the hypovolemia. You should measure the postural hypertension. So there is a next type of blood pressure measuring, which is automated office blood pressure monitoring. In these cases, you don't use the manual type of the sphygmomanometer, but you use the oscillometric monitors, which are automated, and they measure the BP. They take 3 readings at the 1 minute interval. And the benefit is that this system of the BP measurement is unattended by the medical staff or unattended by the family members. So it will somehow cut the chances of having maxed hypertension. So this can be used because it minimizes the white coat hypertension. It also correlates better with the home or the awake monitoring, as well as it also is more accurate than the manual measuring. So it is used nowadays in the many office setup to measure the blood pressure accurately. So next is home monitoring. Because home monitoring is very important because it will improve the adherence to the medications. If any hypertensive patient has a BP cuff at his home or any automated device in the home, then he will regularly measure it. So he will know about his disease. He will know that his blood pressure is increasing or it is in the control. So that will motivate him to adhere to the drug and for the regular follow-up. As well, it also minimizes the chances of suddenly blood pressure going up or down and leading to sudden target organ damage. So home BP monitoring is also an important aspect of measuring the blood pressure. Next is method of measuring blood pressure is ambulatory blood pressure monitoring. You should know this term, ABPM. So it is a gold standard for the diagnosis of the hypertension because in this condition, you will join some kind of the device or BP cuff to a patient, and then patient will do his regular activities throughout the 24 hours, and that device will record his bit to bit or a minute to minute blood pressure throughout the 24 hours. So you can get the average of his blood pressure. You can get the blood pressure while he is awake, while he is asleep, or while patient is engaged in some kind of the physical activity. So you can get the holistic idea of the variation of the blood pressure throughout the 24 hours. So this will provide you the accurate measurement of the blood pressure, so that if you are in any doubt, suppose in any patient with masked hypertension, white coat hypertension, or in those kind of the patient, it is very valuable. As well as in some patients, blood pressure fluctuates from very high to very low. And so in those patients, if you start them on medicine, they will come with the symptoms of hypertension. So in those patients, to titrate the medicine also, we do this ambulatory blood pressure monitoring. So it is usually done in many hospital setup, and even in Nepal, you can various institutes have this kind of setups where they can do ambulatory blood pressure monitoring. So when you are in doubt, you can always ask for this ambulatory monitoring to make sure that patient has hypertension. Okay. So these are the indications where you can use ambulatory blood pressure monitoring, like to assess the presence of white coat hypertension or the marked hypertension, as well as to monitor the medication efficacy, as I have mentioned. Similarly, some patients have blood pressure fluctuation in the night time. There will be nighttime or nocturnal hypertension. We can identify those kind of patients, as well as we can identify the patient with postural drop or those with the postprandial hypertension or hypotension, as well as we can assess the hypotension in case of the autonomic dysfunctions like in diabetes mellitus and Parkinson's disease. So this ABPM is a newer topic and you guys should know this. So this is the chart comparing the cutoff level for the blood pressure according to the various types of the monitoring system. In clinic, you should know this. In clinic setup, we usually take 140/90 as the cutoff to start the treatment. Similarly, in the home BP monitoring, we use 135/85. And for the ABPM, the values are dependent upon the timing of the blood pressure monitoring. Basically, you should understand is clinic measurement 140/90 is considered to be the threshold for the treatment. Similarly, these are threshold for the treatment if you are using other methods of the BP monitoring. So we have now, after discussing all these things about hypertension, you need to know what are the target organ damage or what are the organ damage hypertension can cause. So basically, it can affect every organ of the body. However, there are major organs like brain is affected highly, like it can cause the stroke and the TIA. TIA is transient ischemic attack, which is very common in hypertensive patients. And similarly, hypertension can also damage the kidneys, and the hypertension, it will lead to albuminuria as well as the increase in the serum creatinine and the decrease in the GFR. So you should always screen every patient with hypertension with serum creatinine and the urine albumin, or you can also quantify the excretion of the albumin or the protein in the urine, because if you can properly control the hypertension, or you can use some medicine to decrease the proteinuria so that the renal disease progression can be limited. So you should always screen every patient with hypertension for the renal impairment. Similarly, every patient with the hypertension should be screened for the presence of retinal changes. In every cases of the hypertension, if the blood pressure is not controlled properly, there are chances of retinal hemorrhage, as well as formation of the microaneurysm, as well as the papilledema. And so you should ask the patient to visit the eye clinic to check their eyes once in yearly or in some duration. So blood pressure can also affect the large arteries of the body as well as the small arteries. In the large arteries, there can be the increase in the atherosclerotic plaque, and there will be the intimal thickening leading to the narrowing of the arteries, as well as similar in the other arteries, there can be stiffening of the arteries, which can lead to various kind of the other complications like coronary artery disease can occur, as well as you should assess the blood pressure in the lower extremity to see for the ankle brachial index, because in the peripheral arteries, if there is an increase in the blood pressure, there can be thickening of the vessel, as well as atherosclerosis will be there. So there will be the increase in the blood pressure leading to the limb narrowing, as well as narrowing of the blood vessels, leading to compromised blood circulation in the peripheries, leading to the peripheral arterial disease. So you have to be aware of all these target organ. So you have to be aware of all these target organ damage before managing the patient, because you have to counsel the patient. Most of the patient will be reluctant while you start medicines for the hypertension, because most of the patient will be in their 30s, 40s, and they will have to take those medicines for the lifelong. So they will be very apprehensive and they will be very reluctant. So you have to counsel that if patient does not take the medicine at the right time, they will develop these complications after the 20 years. So we are planning to start you on the medicine to prevent these future complications. So you need to adhere to the medication. We need compliance from your side. So we need to counsel patient in this way so that the patient can be benefited in the long run. So as well as in the heart, it can cause heart failure, it can cause left ventricular hypertrophy, and you have to assess for these. You can assess for this kind of target organ damage using either echocardiography or the ECG. So in the hypertension, it also causes, in addition to the normal other organ damage, there is also important heart disease which hypertension can cause. It usually causes the heart failure with preserved ejection fraction, as well as um, in the later stages, when the heart cannot sustain the pressure, there will be reduction in the ejection fraction. So this is the spectrum of the hypertensive heart disease. You should at least know that in the initial stage, a patient will be asymptomatic. However, in the later stage, there will be the progression from the left ventricular hypertrophy to the heart failure with reduced ejection fraction. So you need to know this because it will help you to manage the case properly. So there are some common risk factors which are common in the patients with hypertension. So when someone asks you about risk factors, you should always say whether the risk factor is modifiable or non-modifiable. So modifiable risk factors in patients with hypertension include current cigarette smoking or even second-hand smoking, similarly presence of diabetes, dyslipidemia, obesity, low physical activity, as well as the unhealthy diet are the modifiable risk factor, which can be modified by the patient so that they can benefit. Similarly, there are some fixed types of the risk factor which cannot be modified. Those are called unmodifiable risk factors or non-modifiable risk factors, which include presence of the kidney disease, family history, increasing age, male sex, as well as presence of the psychological stress. These are considered to be the non-modifiable risk factors. And you should consider, you should ask history about these things, because if you manage the modifiable risk factor, patient may not need the antihypertensive treatment for some time. So you need to know about this. So what are the clinical features? Most of the patients with hypertension will be asymptomatic. They will just present to your clinic with some other conditions, and while measuring the blood pressure, you will find that they have elevated blood pressure. So in most of the cases, they are usually asymptomatic. They come for some other reason, and they are incidentally identified. However, in some patients, they may be found through the regular screening. If they are well educated and they visit the clinics frequently, then in those cases, they can be found by screening. Otherwise, most of the patients are usually asymptomatic. So, however, in some cases, there can be the features. As I have mentioned, in cases of the secondary hypertension, you can find the clinical features, like if there is coarctation of the aorta leading to the hypertension, then in those cases you can find the radiofemoral delay. Similarly, if any patient has polycystic kidney disease, then you can find enlarged kidneys, as well as if the patient has hypertension due to renal artery stenosis. On examination, you may find on auscultation there may be abdominal bruise, as well as some patients who are taking steroid from outside or have Cushing disease or Cushing syndrome. They have the characteristic faces like a moon-shaped face, hump, skin thinning, stray marks. And those kind of features can be present in patients with Cushing syndrome, as well as so these types of clinical features are more prevalent in the secondary hypertension cases. However, in most of the patients with essential hypertension, you will rarely find any clinical features unless and until patient has developed the full-blown heart failure or any target organ damage. In those cases, patient may present with like if the patient has heart failure, then they will present with the signs of left ventricular hypertrophy, which is usually evident on the ECG, as well as the on auscultation, there can be the loud aortic component of the second heart sound, as well as presence of the fourth heart sound. And when the chambers start to dilate, there will be the presence of atrial fibrillation. And in the later stages, they can present with the left ventricular failure, like present with the sign like fatigue, exercise intolerance, orthopnea, PND. Those will be the symptoms in the later stage. But in the initial stage, when before the development of the target organ damage, there won't be any symptoms. So you need to identify patients by taking the proper BP measurement in your clinics. So some patient can present with the blurring of the vision or eye changes, like decreased vision, blurring of the vision, if the retinal damage has already occurred. So this is one important thing you should know. You will be taught about this in the ophthalmology, but you need to know the stages of the hypertensive retinopathy. There's a good chart in the Davidson. You can look at that, and you should remember it because it is frequently asked in the examination. Exam outside. So now, how do you assess the patient with hypertension? So you should screen. So there is a confusion among everyone. So when should we screen, or who should we screen for the hypertension? Basically, if the patient is between the age of 18 to 39 years old age, and who has been whose office BP or whose office blood pressure measurement has always been less than 130/85, millimeters of the mercury. And if there is no other risk factors like high salt intake, family history, obesity, or any secondary causes, then those types of the patients should be screened every 3 to 5 years for the blood pressure. However, if the patient is more than 40 years, patient is obese, or from the certain ethnical group like African Americans, as well as the usual BP measurement is between 130 to 139 or 85 to 89 mmHg, then those patients should be screened every year for the blood pressure, because earlier you diagnose the patient and earlier you treat the patient, you can mitigate the chances of target organ damage. That is our main theme while for diagnosing and treating the hypertension patient. So we just want to reduce the target organ damage. That is all what we want to do. So you can identify the patient who have the primary or the secondary hypertension based on the history. So during the assessment, the history is very important. So if there is a gradual increase in the BP, or if there is associated high salt intake, weight loss, weight gain, decreased physical activity, excessive stress, excessive alcohol consumption, as well as family history, then we usually consider it to be the primary hypertension. So if you cut off this, or if you reduce this kind of the risk factor, then the blood pressure will reduce to the normal. So you have to identify these kind of the risk factors while assessing the primary hypertension. So while if you are thinking of the secondary hypertension, then you should know some important differential diagnosis like pheochromocytoma, kidney disease, hyperkalemia, hypokalemia, as well as thyroid dysfunction, as well as some other Cushing syndrome, use of the medicine from the over the counter. So you should ask for the symptoms related to the causes of the secondary hypertension. Like in pheochromocytoma, you can ask patient for the episodic palpitation, headache, BP liability, fluctuating BP, as well as in case of the CKD, you can ask about the presence of the other manifestations of kidney disease like swelling of the legs and other things, as well as muscle cramps. So based on the cause of the secondary hypertension you are thinking, you should ask the targeted questions to seek for the any kind of signs or symptoms related to those diseases are present or not, to identify the secondary hypertension. So in the assessment of the patient with hypertension, history taking has also got a very important role, because we don't want to miss any secondary causes of hypertension, because if we miss any secondary hypertension and we just treat the patient with antihypertensive, we might be missing the chances of treating the cause of the disease. So you should always be careful about labeling the patient as having primary hypertension. So you should always seek for the causes of the secondary hypertension in almost every patient. So, but you should not order every test for the secondary hypertension in every patient. So most of the patient with the hypertension, 95% will have essential hypertension. So we will be only sending the must-do investigations in them. Like we should test for the fasting blood glucose, because hypertension and diabetes mellitus are closely related to each other and they coexist together. So you should always do the blood glucose level. Similarly, you should send for the blood count, should look for the lipid profile, as well as serum creatinine with a calculation of the eGFR, estimated GFR should be calculated to look for target organ damage. Similarly, we should look for the potassium, calcium, and the sodium level, because they are related to the hypertension. As well as thyroid stimulating hormones should be checked, because hypothyroidism and hyperthyroidism both can cause hypertension. Similarly, urine analysis should be done. We want to see the target organ damage. We want to see whether there is presence of protein in the albumin in the urine or not. If there is albumin in the urine, then we consider that blood pressure, increase in the blood pressure has also affected the kidneys. So that is the reason why we send the urine analysis. Similarly, ECG should be done in every patient with hypertension. We want to see the any significant damage to the heart is present or not. Like we'd like to look for the features of the left ventricular hypertrophy, as well as the presence of the coronary artery disease can be seen from the ECG. So you should order these tests in the as a basic testing for the patient with every patient with the hypertension at the time of the diagnosis. So there are other optional testing which are second step of the testing. Like we can, if there is some changes in the echocardiogram, or if you are suspecting the presence of the heart failure, then you can order an echocardiogram. Similarly, presence of the renal impairment, or if there is presence of renal impairment, then you can ask for the uric acid. Similarly, you can ask for the other test depending upon the patient's profile. So there are other additional tests like which we can do, like carotid ultrasound can be done if you are thinking there is stenosis in the carotids, carotids, or there you can also do some kidney or renal artery imaging and the Doppler studies to see for any renal artery stenosis or presence of fibromyalgia, uh, fibromuscular dysplasia, or you can do adrenal imaging in if you are suspecting some kind of adrenal lesions, or if you are suspecting pheochromocytoma, and as well as you should do for fundoscopy if there is a if the patient has blurring of the vision, or if he is a newly diagnosed hypertension, then there should be strain for the retinal changes, presence of the hemorrhage should be looked. Similarly, brain CT and MRI are done if there is a stroke associated with the hypertension. So in those cases, we do these additional investigation. Otherwise, in most of the patient, we should do all those basic investigations, and other investigations should be done according to the patient's history and the physical finding and the patient's profile. So these are the some tests which you can do for the identifying the cause of the secondary hypertension. Like if you are suspecting primary aldosteronism, you can do for us plasma renin aldosterone level, as well as if you are suspecting renovascular disease, you can do Doppler sonography. Similarly, if coarctation is suspected, you can measure the blood pressure in the legs. If you are suspecting Cushing's disease, you can order the serum cortisol level, as well as in the pheochromocytoma. You can measure the plasma as well as the urinary metanephrin. These are done only if you are suspecting secondary hypertension. So you should not order every patient with hypertension this test, because these tests are costly and they have no added benefit if there are no other symptoms. So this is what this is for today. So we'll talk about treatment in the next lecture.